Hello, I'm Sylvia Richardson. I'm president of the Royal Statistical Society, and on behalf of the joint lab on health data from the Turing and UKHSA and the RSS, I welcome you to this fifth lecture in our international series. Before I introduce the speakers, I would like to hand over to Johanna Hutchinson, who will say a few words about UKHSA, our partners in this exciting enterprise.
Thank you so much, Sylvia, and hello everyone, and welcome this afternoon to this lecture, which I'm sure, like me, you're looking forward to hearing. So I'm Johanna Hutchinson. I'm the Director of Analytics and Data Science in the UK Health Security Agency. And firstly, thank you to Sylvia and our colleagues at Turing and the RSS for the great partnership that we've built and developed over the past 2 years of COVID. And for more information on that partnership and the work that we've been doing, feel free to look us up on the Turing website. Some really interesting pieces of research going on in that area. And then secondly, just to draw your attention to the UK Health Security Agency, which is a new entity in the government and brings together the former Public Health England, the Joint Biosecurity Centre that was designed in COVID times, and the COVID Test and Trace programme, which you guys in the UK will be very familiar with. And really what the essence of the UK HSA is to build on the experience of COVID and ensure that we're as vigilant and have the right skills and capability in place to be able to take the country forwards and understand the underlying health conditions and the health security of the nation. So it's a really exciting task at this time. So some of the core building blocks of UK HSA, which we'll be building on and taking forwards, and looking forward to partnerships with many people on this call and beyond. And so looking at scientific excellence, a real emphasis on data analysis and surveillance, operational agility and flexibility, being able to be responsive in a timely manner, looking at global health security and preparedness, lots of work in that area these days, and then forging really strong partnerships, both with the wider system, in academia, in government and in industry as well. So we're really looking forward to a bright future, to be able to take this area of government into a new phase and be able to represent England on the health security stage. But enough from me. Thank you very much to our speakers today. I will let Sylvia introduce them to you. I'm really looking forward to your talk. Thank you.
Thank you very much, Johanna. So as I said, this is the fifth lecture in our international series. We've heard from American colleagues, French colleagues, Australian colleagues, and it's very important to learn from different approaches that teams have taken, modelers together with the public health authorities in different countries, and to get to learn lessons from that in terms of preparedness. So today we have two colleagues from Norway, Dr. Birgitte Blasio, who is professor at the University of Oslo and department director of the Norwegian Institute of Public Health, and she heads the COVID-19 modeling team. And she has collaborated very closely with Professor Arnoldo Frigessi, who is director of the Oslo Center for Biostatistics and Epidemiology, also in charge of a major initiative called Big Insight, which is a consortium of partner from academia and industry. And together they've worked very closely to develop these models, and we look very much forward to hear from them about situation awareness and forecasting of COVID-19 in Norway and how they've worked with the public health authorities. And I think Birgitte is going to start, and then Arnoldo will follow. So Birgitte, the floor is yours. And thank you.
Thank you.
So I just want to say also, people, get your questions ready. There will be time for questions at the end, and you could put question in the chat or wait till the end, but get your questions ready in your head as the seminar comes.
I hope, thank you very much for the opportunity to come and talk about our work in the COVID-19 modeling team. at the Norwegian Institute of Public Health. In my presentation, I will provide some context around the regional situational awareness modeling, and Arnoldo will go later into the more technical details. See if I can make it. So the Norwegian Institute of Public Health is a state agency under the Ministry of Health and Services. The institute is responsible for national surveillance. We are a knowledge producer and do research on infection control, and we give advice and assistance to health authorities, health professionals, populations, and the media. In Norway, there is a high degree of decentralization. So there are regional health authorities and also municipal level health authorities. And during the pandemic, in general, political decisions have been informed by advice from the Norwegian Institute of Public Health and other national agencies. In particular, our institute publishes regularly risk evaluations and strategic reports where modeling have been a central part of the knowledge base. In line with other European countries, the aim of the Norwegian strategy to control the pandemic has been to assure a manageable burden of COVID-19 hospitalizations, and in particular intensive care patients, and to prevent COVID-19 death. In Norway, we have had particular focus also on protecting elderly and vulnerable groups. Overall, we can say that the Norwegian approaches can be described as a precautionary-based response. Already from the get-go, the lockdown in March 2020, we had an early and very strict response. And later on, in particular in periods with large uncertainty, for instance, due to new variants with uncertain severity, we have also had a very early and very strict response. The Norwegian strategy has relied on what we call TISK in Norwegian: testing, isolation, contact tracing, and quarantining. And in particular, I want to highlight the rigorous local-based contact tracing that has been in place from the start, with also online educational support and support from the national team at the Norwegian Institute of Public Health. We have used emergency powers for isolation and quarantine, also for travelers coming from abroad, where hotels has functioned as quarantine facilities. From the autumn of 2020, there has been a local differentiation of measures based on local infection levels. And although Norway has invoked this National Preparedness Act in 2020, most of our measures have actually been based on recommendations, and there is a high degree of social trust in the population. One could maybe also mention that we have a well-functioning welfare system that ensures payment in the case of sickness or unemployment. Here you see a graph showing the daily new confirmed COVID-19 cases per million for Norway. Let me see if I can move this bar so I can see the figure. From Norway in green and from the UK in red. After the lockdown that we had in March 2020, there was a resurgence in the autumn of 2020, and another resurgence coincident with the dominance of the Alpha variant that came in February, March of 2021. Then we had a shift over to the Delta variant during the summer, and we saw a new resurgence in the autumn. Also, there was a try to go back to normal. And then in December, the Omicron became dominant, and we entered into a new period of strict measures that has gradually been opened up. And now from March 1st, we are in a completely open without any measures. As you can see on the figure here, we have a downwards trend now in Norway, so that we are over the peak of the current peak. And you can also see that apart from the very last period, the number of confirmed cases in the UK has been higher than Norway, but of course it's hard to compare because it's based on both capacity and criteria for testing. Regarding vaccination, like in the UK, we started to vaccinate around 1st of January 2021. The rollout was slower compared to the UK, Most of our vaccinations occurred in the summer of 2021, and we reached the level of the UK coverage only in September. Per March 2022, we have a coverage of the vaccine dose of around 80% for the first dose, 75% for the second dose, and around 50% for the third dose. The precautionary principle in Norway becomes visible when comparing hospitalization data. This figure here shows for Norway in red and for UK in green, number of admitted patients in hospital per million. We can see that apart from the very early phase, except from the very early phase, we have actually had the highest number of hospitalizations, but we have had consistently lower number of hospitalized patients per capita than in the UK. And the same picture emerges when we look into the daily number of confirmed COVID-19 associated deaths per million people. Overall, we have had around 2,000 deaths in Norway, similar to 300 per million population, which is almost a tenth of the number that has been reported in the UK. When we look into the picture, into the details, the pandemic has been quite heterogeneous geographically in Norway. And Norway has a population of around 5.5 million, and most of them are situated in the southern part of the country. Oslo, the capital Oslo, and the surrounding region Viken have had consistently high infection pressure, whereas elsewhere in the country we have observed spatially shifting epicenters that we have been able to stamp out, among other things, with the use of effective contact tracing. The fact that we have a very heterogeneous picture of infectious spread with high variation in local infection levels, and also because we have a localized infection response, warrants the use of a regional model. And the regional model has been used to make informed adjustment of prevention policy throughout Norway. In Norway, a new real-time preparedness registry was initiated in 2022, named Birgitte, where data are merged, raw databases from various registries are merged at an individual level, including the lab database, the Norwegian patient registry, intensive care registry, vaccination registry, and so on. With respect to modeling purposes, test data have been challenging for us due to widely varying capacity and criteria for testing throughout the pandemic. From the autumn of 2021, there has been extensive use of rapid test kits. First, they should be confirmed with a PCR test, but later not. And this has led to a degradation of the quality of the test data because these rapid tests are often not reported. Throughout, there has been a lack of randomized seroprevalence studies, implying that it has been also difficult for us in the modeling group to calibrate our models with respect to cumulative infection numbers. Here you see the COVID-19 modeling team consisting of 16 people altogether, and it was formed in early 2020 as a collaboration between the Norwegian Institute of Public Health, the Norwegian Computing Center, the University of Oslo, and Telenor Research. And it was actually a continuation of an already existing collaboration on spatial modeling with use of mobile phone data. This is a great team, and I'm very privileged to have been the manager of in 2 years. It has been very exciting and an interesting learning period, but also in periods with tremendous workload. One of the first things we did was that we established a real-time analytical pipeline. So we have the data infrastructure, the emergency registry data that I talked about before, mobility data, 6-hourly mobility data, and data preparation that was interfaced then with high-performance computing as servers with up to 6,000 nodes. After that, we also tried to interface with a semi-automatic write-up of reports. The tasks in the modeling team are different. A core a core task for us have been situational awareness through estimation of both national and regional reproduction numbers. We've been estimating cumulative infections and detection probabilities. And then we have been doing short-term predictions, looking 3 weeks ahead. What will be the number of people in hospitals? How many people? How many intensive care beds do we need? And so on. Our core delivery has been a weekly modeling report. It actually started out in the beginning of 2020 as a daily report with more than 110 reports delivered so far. And this is online, and you can have a look at it by clicking on this link here. We also, as I mentioned before, is part of risk evaluation, and we deliver every week data files to both regional and municipality level health authorities. Another thing we do is that we have been doing a lot of scenario-based modeling using other types of model than what Arnoldo will present, among other things, individual-based models. But those models and those simulations have relied on the estimates based on the situational awareness model, and in that way they are linked. Among other things, we've been looking into prioritization of vaccines, both with respect to age and risk groups and geography. We have been making planning and strategy reports where we look into long-term scenarios. We have made contributions to health economic evaluations, and here during the Omicron wave, where we for the first time have reopened society full, there's also been a need for doing sick leave estimation and working on, for instance, reducing the quarantine duration, the consequences of that. Finally, we've been looking into new variants and done trend analysis of various data sources. Just as an example here, this is a report, a modeling report that we did to compare a national vaccine rollout with various strategies for regional prioritization, showing a benefit of prioritizing regions with high infection levels. This report was delivered on May 10th in 2021. And on the 19th of May, 9 days later, the government made a decision to actually do a geographic prioritization of vaccines. Lastly here, this is a cover from one of the national newspapers in Norway called VG, where our reproduction numbers have often been reported. This is from the Easter of 2021, with the good news that now the R number was below 1 after a previous search. Thank you for the attention and looking forward to answering your questions.
And Birgitte, I take over now.
Yeah.
So if you stop sharing, I will share my thing. Here it is. And what I plan to do now is to guide you through some of the details and aspects of the modeling that we have been using in these 2 years. I'll tell you a little bit about data with focus on the mobile phone mobility data that we were very lucky to have, the modeling with our metapopulation compartment models, how we had to do inference to cope with real-time requirements, a little bit on results and some comments. The data, as Birgitte was saying, the data are good in Norway. There is a high quality data feed. Every morning at 6 o'clock, there is a good picture at municipality level. There are 356 municipalities in Norway. And we used a number of positive PCR tested and positive cases, number of tests used at all. We used the number of imported PCR lab confirmed cases, mainly based on testing at borders, but not only. We used the new admitted COVID cases at hospital and the mobile phone data. We did not use admission to ICUs, and we did not use deaths in our modeling. It was used as validation in various settings. And as Birgitte was saying, we didn't have any good randomized seroprevalence studies available like you would have in the UK. The data starts with the 5.4 million Norwegians that are distributed in Norway in 11 regions and 356 municipalities according to where they live. And mobility was represented by how mobile phones which are connected to the main mobile phone provider Telenor in Norway were moving in Norway. So we have data, we have had data that counts the number of people moving between each of the 156 municipalities every 6 hours, with some censoring for privacy if this number is below 20. And Telenor has roughly half of the market, and we simply scaled up. These data are in itself very interesting because we could look to them and see how people move, and in some sense this describes how people are having contact with each other. You see here, for example, the red curve down there is Oslo. The number of movements outside Oslo every day collapsing very rapidly in the first lockdown in the beginning of March 2020, and then remaining low, and now having reached again the pre-COVID situation. Lots of traveling in the north of Norway where there is distances and people have to move to go to shops and hospitals and schools, and in particular in winter, in the summer, a lot of tourism in the north of Norway when Norwegians were not allowed to go to Spain and Italy and all these other nice places. So every 6 hours, we move the individuals that have an attached label where they are resident to the municipalities where Telenor matrices tells us to move them. And when they are there, they mix randomly for 6 hours. We have to decide how to move people because these mobility matrices, they tell us that, let's say in these 6 hours, 300 people moved from a municipality I to municipality J. So how do we choose? And we decided to, first of all, send back the residents in J that are currently visiting I. And this is to try to represent commuting, which is one of the biggest mobility aspect. And then if more individuals were needed, because we need to send back 300, then we would send back other visitors from other municipalities that are present in J into I. And finally, we would send residents of I into J. And we have switched these orders a bit to see if this matters, and it did not matter particularly. There is an issue of preserving the population, because if these matrices would be perfect, so xijt would be the number of people who are at time t-1 in I and then are at time t in J, then there would be a perfect equality in that thing that you see down there, because this would mean that the population is preserved. But it is not the case, because the Telenor data are incomplete, a bit because the phones are not connected, because they're censored, because they're exiting Telenor's network and so on. This means that it can happen that municipalities get depleted while we are proceeding with the model, right? And this in fact happens in particular in smaller municipalities. And in these cases, we simply add the people that are missing, and we control that this number is not too big. When we do predictions, we need to say something on how the mobility will be in the future. And there we take a simple decision. We take the last full week of data that we have and repeat it in the future. And we take care that vacation periods are like this. But in these cases, we want to preserve population, but because when we do predictions of a year ahead, then the depletion will be serious. So we need to preserve population. And this we do by finding the closest matrix to the one that we get from Telenor, where row sums are equal to column sums, and use this regularization before we apply this mobility in the future. And this worked very fine. The last data sources that we use is the number of imported cases from abroad. And here you see a plot of this data. This is also used for seeding all our compartment models all the time. We recognize that not all the people who are positive are detected at the border. We therefore assume that every person that is found stands for A cases, And A is one of the parameters, we call it the amplification parameter, that we have to estimate. And this has also changed over time because of different type of border controls that Norway has had in place. The model, compartment model, you have seen many. They're all a bit the same, right? Susceptibles, then the ones that are infected are non-infectious for a short period. Then it can be either symptomatic or asymptomatic. If it is symptomatic, there is a pre-symptomatic phase where there's very infectious, and that's the big problem or one of the big problems of COVID. And in the asymptomatic case, this is not there until people recover. Very simple serum model. And then we have lots of rates and parameters that have to be decided upon. And here you see the ones that we have been using most of the time. These numbers come from the literature. For example, that roughly 30% of the infected are asymptomatic. This number has changed over the period, and we have always tried to capture a decent estimate, but this number is not estimated; it's fixed. And then we see, for example, we assume that the time of being exposed and not infectious is assumed to be exponential with a mean of 3 days, and so on. And beta is the famous beta in these models. This is a probability of transmission upon contact times the contact rate, and it is different for every region F and for every day T. And as I said, this model is seeded every day continuously by the imported cases. We need to connect the data to the model to data, so to the hospitalization first. And this means that I have to describe how infectious and symptomatic individuals are sent to hospital. And this means that I have to model a probability of being sent to hospital, given that the person is infectious and symptomatic, and the time it takes between the moment of being infected to the moment people are hospitalized. And we start with data from a very early paper, July 2020, the famous Salje paper, where there are estimates of the probability of hospitalization per age group. And this is both asymptomatic and symptomatic, but we use it for the symptomatic case. And the first thing that we do is that we have to compare these numbers with the situation of the demography in Norway. So we scale them to the demography of each municipality, and also correct it for the fact that there is a high percentage of elderly living in elderly home in Norway that would not be sent to hospital, but for example would die in elderly home. So these are the probabilities of hospitalization that we would obtain at that point. And in this case, the only assumption we would have made is that the disease burden follows demography, but this is not the case, right? So if we look to the age groups that are present in the tested, so these are in the positive cases. So this is looking every day to what is the percentage among the positive PCR tested in the various age group. We see that it varied, of course, very, very much. And in fact, these distributions are regionally varying also very much. Here you see 3 different regions. So we had to learn the distribution of age of the infected from the PCR confirmed cases. And this, in fact, also includes the effect of vaccination, which in Norway followed age groups very clearly. So we computed a correction factor for each age group. And this factor, in fact, is updated every month because these probabilities are changing every month. And in addition, we had to take into account the variants, which also alter the probability of going to hospital. And in various forms, we have increased these probabilities of a factor 1.6 in both cases, based on the literature. How much time does it take from infection to hospitalization? Here we go back to the Norwegian registry data, and they are good. And they tell us, for example, that before June 2020, the time between onset of symptoms and hospitalization can be approximately quite well with a negative binomial with a mean of almost 9 days. And so on. All the other quantities are quite well estimated through a very rich registry of data. But it turns out that these numbers are changing. For example, between January 21 and March 21, the mean of the time between onset of symptoms and hospitalization was only 7.6 days. And in fact, in Oslo, it was even smaller. So these numbers are complicated. They change in time and they change in space. And a very big effort that we have been doing in our group is to follow them very carefully and monitor these quantities in the registries to always be able to use the most updated estimates. To use positive PCR confirmed cases, I have to say, what is the probability that a PCR confirmed case that can be symptomatic, asymptomatic, and so on, is detected by testing? And how is the delay between the infection and the test? And here we assume that the number of confirmed cases at time t is binomially distributed among the infected at time t, which is estimated in our SIR models, and the probability of detection pt, which we assume is dependent, linear dependent, logit linear dependent on the number of tests made on that day, thinking that the number of tests made is a proxy in some sense of the effort made to detect. But of course, this is only very, very rough approximation. We estimate P0 and P1, and they are also time dependent. They changed approximately every 3 months. They are re-estimated. The delay between day of testing and day of transmission is also estimated. It's assumed to be multinomial between 1 and 4 days. We know that we don't capture the changing of criteria. Now, the testing criteria changed in Norway, maybe not as dramatically as in other countries, in some other countries, but they did change. And today, as Birgitte was saying, we are not using test data at all anymore because the antigen self-tests are not reported and we don't have this data anymore. The betas, they are either assumed to be constant in intervals between change points, and then we use sequential ABC to do inference, or they have been also assumed to be daily varying with a random walk model and sequential Monte Carlo. I'll tell you a little bit only about the first of these two approaches. So the idea here is that we simply assume that there are change points in the reproduction number or in the betas, and that are constant between change points. And these change points are not estimated. They are set by hand when interventions have changed, and otherwise approximately every 4 weeks. So these change points are different in every region because interventions have been different in every region, but are not estimated, are set explicitly on days where we think that a change in transmission can happen because of a different control of contacts between individuals. Inference, it's not easy because at this point we have these 11 counties and about between 10 and 20 betas for every county. So this is 150, 200 parameters. We have then another 4 parameters that we have to estimate: the amplification factor, these probabilities of detecting a case, and the delays. And then, of course, there is this enormous quantity of latent variables, all the compartment in all the countries. What is important is that because new betas are always coming, the number of parameters is growing in time. So here you see, for example, in July, we had 15 change points in Oslo and estimated therefore 15 reproduction numbers at that point. Today we have much more. And here you would see the estimates of the reproduction numbers from the betas in these 11 counties a couple of weeks ago, I think. Now, how do we do inference? We use approximately Bayesian computations. And the idea there, as many of you know, is that you think that the data that you have is the realization of a true likelihood model M and a true parameter theta that you don't know. And then what you simply do is that you try many theta primes in our model that can simulate hospitalization and test and number of cases and number of positive cases, D prime, and then you compare how the true data D and the simulated data D prime compare to each other. If the distance is smaller than some epsilon, then you would keep theta prime as a good parameter that potentially explains the data themselves. Now, we use the sequential Monte Carlo ABC approach, very classical approach in approximate Bayesian computation. That goes like this. You start by sampling from the prior 1,000 sets of parameters. Each set has 150 parameters, for example, right? And then every round you do the following. This is an iterative algorithm, so assume that you are at round R. Then you draw from the parameter that were accepted in the previous round. I'll tell you how in a minute. Then you perturb them a bit to explore a bit more the parameter space. And then you accept these set of parameters if the simulated data and the true data have a distance which is less than the 80th percent quantile of the errors that you found in the last round. So you see we have the hospital data H prime that are compared to H, the simulated test data T prime that are compared to T, and these epsilons are reduced round after round of a 20%. So it's a very demanding algorithm. And every time we wait until 1,000 sets of parameters are found to move to the next round. And if it is difficult to find 1,000 parameters, it takes a lot of time. Now, the perturbation is very simple. I take the parameters and I do a slightly Gaussian perturbation around them using a covariance matrix that is well estimated in the previous round. And the drawing of the parameters is an important sampling drawing. And these are classical ways of doing it. And here you see, for example, an output. On the left-hand side, you see the distribution down there in the bottom in round one of the reproduction number for one of the regions, and how this is concentrating more and more while we are learning from the data while the rounds are passing. And here you see another region where things did not go so well, where there is not much information in the data, and the uncertainty on the reproduction number at the final round here, 33, is still very big. Now, an important thing for us has always been real time. I mean, situational awareness and predictions is something that you have to sell on the day it's produced, right? So our aim has always been, we get the data Monday morning, 7 o'clock, and we are done after 48 hours. We produce our reports Wednesday morning. And this was limiting very much what we could do. So the ABC that I told you now would never converge in 48 hours. So we had to think differently. And we developed something that we call the Splitted Sequential ABC, which has a very simple fundamental idea and says that the old reproduction numbers, the one of a year ago, they're not so important. Can we make an effort to estimate them very well and then keep this estimate in the future? And this is the idea that is behind the sequential split ABC. So we start with a period from the beginning, let's say February 2020 until January 21, and run a sequential ABC with very many rounds. This ABC can run for weeks and weeks and weeks until we have 1,000 parameters that, including all the latent compartments, until the split point. Then the next period, let's say from December 21, until August 21, the next split point, That period now is the one that we want to now calibrate. And as you see, we overlap the two periods first. The idea is that a 2 weeks overlap is important because I will use, in these 2 weeks overlaps, I will use the parameters that were well estimated in the first round to start the next one. This is a way to move uncertainty from one from the first big experiment to the second period. So we sample the parameters set from the first run, which belong to overlapping period, and calibrate the parameters, the betas, in the second period. And we continue like this all the time, right? And when we come to the very last run that ends today, this is the piece that I will run on Monday morning. The rest, I have made all the efforts before, and I only need to use the 1,000 good parameters and all the compartments that are ready for that point. I run only the last piece. And I say that this has happened only once, but in reality, because we change assumption, we have to rerun all these old parts often, but they can be run somehow offline, right? 2 weeks overlap because this covers the hospitalizations that are produced in the previous period ahead. And it is even a bit more complicated because we want to also use a bit more data in the previous round so that the hospitalizations that are produced 2 weeks after the December 21 are also used so that we can, because they say something on the transmission in the first period. This is complicated, but the idea is we split the time and make sure with overlaps that we can propagate the uncertainty in a decent way. It's not finished, unfortunately, because we have still a problem with the regions that don't have much hospitalizations and don't have much cases. These are about 8 of the 11 regions in Norway, right? So they are not well estimated at this point, simply because the bigger regions, they control the acceptance probabilities, right? Now, one could do a calibration of every region separately so that you wait until all the regions have the right parameters. This is impossible because you would wait for the 1,000 sets for days and days and days. So this doesn't work. So what we do here is, in the last round, we do something that first considers every region alone against all the other 10 regions that share a beta. So this is not many parameters, and we lose the mobility between within these 10 regions, but we still have the mobility between these 10 regions and the one that we are considering. And these 11 runs can go in parallel. This gives us 1,000 set of parameters for each of these regions. And now we can use this as a prior in a final run where everything is together. Here we learn the spatial dependencies, which are so important because of the mobility, and produce that as our final results. Here you see, for example, in a recent case, how these convergences went in the last part. Briefly on the results, I check time. Yes, very, very rapidly. So this is the fit of the data to of the daily incidence data of the infected for the Oslo region. The last 4 dots are in red because there is a reporting delay, which we correct also all the time. Here you see the fit to the hospitalizations in Oslo and the prediction to the next 3 weeks. This is Viken, another region, the incidents, and here you see the hospitalization incidents with a prediction for the next 3 weeks. How did those predictions go? We can go back in time and see how things were. Here you see, for example, a case where we use data until the 31st of March. On the left, the region of Viken. The yellow dots is true data. They have been used to produce the prediction that are these blue bands that you see down there. And the red dots is then the true data that were observed in those 3 weeks. Not too bad. And Oslo on the right-hand side. This here is another period. This is in February. And here you see that, for example, in weekend, we really underestimated the hospitalizations. And this is to do with the fact that test data and hospital data are not necessarily coherent, right? In fact, when we do this prediction using only the hospital data and no test data, we do a much better prediction. And this has to do with this inconsistency between the data that our model alone cannot detect. Is it worth to use all this complicated regional modeling and the telenormobility compared to a simple national one? And the answer is yes. And we do this by computing proper scoring rules that study the quality of our probabilistic forecasts. And this that you see here is called the energy score by Igniting and others. And these scoring rules, they take into account both the coverage of the truth by the credibility intervals and the width of the credibility intervals. Estimated probability of detecting an infected person, roughly 60% in Norway. And I conclude very rapidly with a couple of thoughts. As Birgitte was saying, we were followed by the press. Here you see VG, one of the important newspapers in Norway, that discusses how our uncertainties were very different in making these 3 weeks prediction in certain periods. The top one is a prediction that we did in April 2020, where things were really, really difficult. It had just started to flatten, and we didn't really know, or the models didn't really know. Much easier in the summer 2020, when things were completely clear. The newspaper have misunderstood us very often, as I'm sure happened also in the UK and everywhere. For example, this was on a certain point in June 21. Horror scenarios did not strike. It was wrong time after time. And we were, of course, a bit nervous when we saw these things. And this is to do with the fact that every time we do a prediction, in particular when they were very serious, right? Then the municipalities intervene very rapidly, and simply people, by looking to these results, change their behavior so that these serious situation almost never showed up. It's also the opposite. Sometimes our things were too optimistic, right? And to close, we change the model all the time, which is a problem in communicating results. We try to be close to what is known and what we understand from the data. Every box is a change that we introduced in these 2 years. And I finally conclude by saying that it was really very interesting to read this paper, Interoperability of Statistical Models in Pandemic Preparedness, Principles and Reality, by George Nicholson and many others, including Sylvia Richardson. This is a beautiful paper that tries to describe in a principled and methodological way the modeling work that we have been doing in these 2 years. And it fits so well with what we did. So the point of this paper is, how do we have all these different type of data, right? The testing, the hospital, and blah, 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 right? And one way of doing it could be to estimate reproduction numbers using each of these data on their own and try then to put them together in some way. The other extreme is to build a mega model where everything is included and then uncertainties are so well captured and so on. But that model will not work because of the constraints that come from the operational aspects, from the political decision-making that requires results and the real time. So there is a middle ground, it says in this paper, in which we develop models and analysis plans and couple them together. And we feel that our work fits exactly in this context. And I'll stop here. Thank you.
Well, thank you very much, Arnoldo and Birgitte. Very interesting, very challenging. You know, I'm full of admiration about the complexity of the task and the that you've tackled. So we've had lots of questions in the chat. I'm going to try not necessarily to ask them in the order, but try to organize them a bit with respect to your presentation. So there's a question by Fabienne Cryer about the mobility estimates, which is a big thing, which you started with, saying how does the Telenor for data compares with mobility reduction from the Google app data? And can you comment on how commuter mobility relates to actual contact reductions? For example, collected in surveys, like the comic surveys, if some surveys exist in Norway about that.
So Birgitte can answer on the comparing this with the polymer data and so on. We try to look to the Google data and the Telenor data, and it is very interesting to see how different these mobility measures are. The correlations are very weak, very, very weak. I mean, these things measure different things, and our mobility is in some sense a long distance mobility, right? Because it's between municipalities. It's not me going to a shop in Oslo and going back. We have also this type of data from Telenor, which is very different, right? So we decided to use this one because Norway is so long and big, and there was so much difference between the regions. We thought that was the most important information. And the information has been very, very useful in the beginning of the epidemics, and every time there is a change. When everything has a high reproduction number, you don't need to move people in any clever way.
Thank you. There's some question about the model itself. So from Comchen, how do your model address probability of reinfection and depletion of the susceptible cohorts? And do you consider variants separately? And how does vaccination come in your model, basically?
Birgitte, do you want to answer?
I couldn't hear properly.
Okay. So reinfection, we don't have reinfection. Reinfection is, we don't model reinfection. And the other question, Birgitte, was vaccination. How do the vaccination goes into our modeling?
I mean, what we are doing is that we are estimating an effective reproduction number. So in reality, we are just trying to estimate effectively how many people to one person infect. So we don't have vaccination in the model per se. We have done a change now because there is, of course, a change in probability of being hospitalized. So in the later period, we have looked at vaccination in the context of hospitalization risk. But in this situational awareness model, we don't have any vaccination.
It comes in through the fact that we control the probability of being hospitalized, right? Yeah.
Yeah. Yeah.
And another question about the model, which is...
And maybe we should say that the reason why we didn't do more compartments and things like this is that we had to be very careful on the number of parameters here, right?
Yeah. Yeah, because we have a highly, spatial model with high granularity, and therefore we cannot have so many other parameters. So there is no, in the model itself, there is no age, there is no vaccination. We get an age effect via the test data and the hospitalization risk and these procedures that Arnoldo explained. But in the model itself, we don't have any age.
One, I think, a simple question on the model from Luca. Why is the contact parameter taken and multiplied by the rate of transmission to get beta? What assumptions are made to consider such a dependence? And then the next question is, what is the uncertainty in the model on beta in a given region and at a given time?
Yeah, so the estimate of the uncertainty of the reproduction number comes from the fact that we have we simulate the future or the situation many times, right? So we lack, so the uncertainty comes from it doesn't come from the many parameters that we fix. So we know that the uncertainty is too small. You've seen it also in the results. For example, when we say that only 30% of the infected are asymptomatics, this is of course not right, right? So we have a big underestimation of the uncertainty. we have no idea how much that is. Also because there are no good estimates, for example, on the uncertainty of the percentage of asymptomatics. And a point on the immunity, I see this question now. I mean, Norway had very, very low seroprevalence, right? Until November last year, it was around 4%, Birgitte, something like that. So it was not problematic. But of course, now it is a different story. Yeah. Mm.
A question from Peter about the density, saying that in Norway there are some areas with high density, population density, and low population density. Is there a way of incorporating this into the modeling, especially about how people mix within municipalities? It's a huge, very spread municipality. It's probably different.
Yeah. I think, of course, there are, but then I would rather think that one should go to an individual-based model and really model, each individual. Then you can have these kind of effects. I think it's not feasible, I think, with this kind of metapopulation approach to also have this considering all these parameters that we need to estimate. So I would rather than opt for an individual-based model that we also have that we haven't presented now, but that we also.
Okay. That's of way. There's a question about basically the operational challenges. I see that, Birgitte, you touched on this is from Jason Ward, touch on the real-time analytical pipeline. Were there any challenges learning for the production of the models, the whole pipelining? What things you learned as you went along, and so what would be your
I would say, at least from experience, is that one of the hurdles we had to overcome was this person-sensitive information that are in this preparedness registry. It has been quite difficult to get access to data, but we have managed that. But that is clearly a hurdle in the Norwegian system, that it's very hard to get access to data. Then another thing I would mention is the costing side. It's this 6,000 nodes on this high performance service costs around last year. I think it was £1 million. It's quite expensive for us to finance it. And then I think, because we have also been doing commissioned work. So I think there has been, one of the challenges for us has been in periods that have been crowding. Too many people wanted to do simulations at the same time because everything was in a hurry. So that was sometimes a problem. Otherwise, I think
which means, for example, that we never check that the codes are without bugs, right?
Yeah.
For example.
It's a very different way when you have to work in real time and you have to give policy advice in an ongoing epidemic, because you cannot go back and think, could I have done it in another way? You have to deliver a report in maybe 2 days, and you have to do the best you can. So it's a way of changing your mindset that you need to undergo when you're a researcher, when you're working in this kind of operational work. It's quite different than from doing research where you can go into your office and close your door for 3 months and come out with something smart to say, right? You have to be on.
The whole of UKHSA is with you.
Just back a second to the question of Peter. I mean, the connectivity between the regions is governed only by this mobile phone data, right? So that takes into itself the volume of these different areas, right? So the Oslo people, they are going out much more than from other places coming in. So I think that we captured that well enough. But as mentioned, we have this problem that these data don't preserve populations, right? And that is something that we accepted by simply adding people. I know, for example, that currently we have added 300,000 people to Norway. It's not nothing after 2 years, right? And we are discussing a restart now, for example. And but everything is not so easy. Restart means to redo everything. Restart from, so it's something that we have to plan very well.
But if I understand the question correctly, it's also about that if you have a less populated area, then they actually don't interact with one another, and you have this kind of spatial pockets that we don't catch.
Okay.
And there, I think this individual-based model we have, where we have very high detail granularity, where you can have cells with only 400 people in each cell, and you model the spatial density very correctly. I think that would be a better approach than to try to improve it with our metapopulation model. But yeah.
There's a follow-up question by Robert Hinch about have you looked at the model estimate of imported case versus local transmission, and were there times where you think the epidemic was sustained by a few core regions as you look, rather than being spread? So, sustaining within each region, or really being influenced by other region. Do you have any, when you were looking at the sort of relative trace of these imported versus local?
Yeah.
Or was it all in kind of some kind of sync?
Yeah, I don't know, because I think we have had many discussions about this amplification factor estimation and how useful it actually is and what it actually says. I think in the beginning of the epidemic, it was useful because there were very few cases and we need to amplify it up. But we have had many discussions about how we should really interpret that now in the given situation, and what kind of the quality of data we have to inform it. So I would say I'm a bit uncertain about making very decisive conclusions, but I don't know what you say.
We were very surprised that we could estimate it at all,
yeah.
Right? Because it looks almost non-identifiable, right? And this is to do with the fact that the models are so strong in their exponential assumptions, right? And therefore it can be estimated. But what does it really represent? It's difficult. I think the estimate has been oscillating between 1.2 and 1.8, something like that. Maybe it came to 2 briefly, but that was roughly what it was, right? So meaning that we missed half of the entries, which is not an impossible situation. Could well be.
A kind of concrete question: which programming language was the model written in, and how many compartments are you dealing it with in total? More than 100, I presume.
So compartments, it's 11 times 5.
Okay.
It has, the core is written in C, and there's a lot of R wrappers around. It's mainly C and R wrappers.
There was the question right at the beginning about something about long COVID. So this is not really related to your model. It's a question by Jean-Marie Carey about what's the opinion of Norway, public health, on the study released by Nature this week about long COVID experience by otherwise low-risk patients, and why does Norway continue to present what's clearly a mass disabling event as like a cold? I don't know why this is stated this way, but I'm just reading the question about what's the Norwegian perspective on non-COVID. Let's put it that way.
Yeah, I think for me it's difficult to answer this about long COVID. I think it's more maybe for epidemiologists and immunologists. I'm not an expert in that. Is it the study from Haukeland's hospital? I don't know, but I think I'm not qualified to answer.
But we can maybe say that in the beginning, the focus was to prevent the healthcare system to collapse, right? And to reduce the hospitalization. In this Omicron wave, there have been a lot of attention also to the number of cases even if not hospitalized. And the main focus was really sick leave and not be in a situation where the garbage would not be collected, right? Because everybody would be sick. But I mean, there was also an aspect of long COVID in that discussion. And of course, now very many Norwegians have got the Omicron, right? And it is an issue in some sense. That's my personal opinion.
We are doing a follow-up studies. We have cohort data. We are collecting data for cohorts. We have very large cohorts on 100,000 people where we try to collect information on long COVID, and we have registry-based studies. So we are doing serious studies on COVID also at FHI, long COVID.
I think we need to wrap up. There may be a last question, more technical question from Jason to Arnoldo. What factors dominate in the estimates of uncertainty? Is it dominated by the parameter perturbation or other things like model assumption, data bias contribute significantly? This is a very difficult question. You know, just
I mean, first of all, you have to see, I mean, we have very, very little data, right? To estimate all these parameters. We have the number of new admissions to hospital every day, right? And the number of tests that maybe we don't have them either, right? So it's very little data. And then there is this issue that the two data sources, the three data sources can be incoherent. And what does the model do? It enlarges the uncertainty, right? To try to cope with that, right? So, and we have been thinking a lot, and I would like to go back to this, to how do we understand automatically in some sense when data sources start to be incoherent, and what to do? How can a model defend itself in this situation? And not simply, because of course the model does some averaging, right? Whatever, I mean, compromising, right? But how do we avoid the compromising and instead downweight the data that start to get worse, right? And if you write the suggestion to me, I would be very happy to read it.
Okay, so Jason, you've got a follow-up answer to give to Arnoldo now to his questions to you. We look forward to read that. I think, you know, we've run already a little bit out of time for the seminar. So I think it's time to sort of wrap up. And you know, I think you will have access to the questions still. Arnoldo and Birgitte,
Thank you.
Want to give. I mean, Dee, am I right in that? So that if we want to add some answers later on. Otherwise, I would like to thank you, thank everybody, particularly the speakers, but also all the people who've come to the numerous people who come to listen and have asked questions. And I think it was very brilliant presentation. I also want to remind you that there is a next planned talk in this series. And this will be Crystal Donnelly, so from the UK, coming in April sometime. Haven't quite got.
Is it 28th, I think, Sylvia?
Okay, 28th of April. 28th of April. So very happy to see you there. And again, thank you very much, Birgitte and Arnoldo, for this very exciting talk. And I see Peter is also writing notes of the.
Thank you very, very much for inviting us and for all these very good comments and questions.